Nice video.
Hello and welcome to this webinar on direct peritoneal resuscitation, which is brought to you by ESTES, the European Society for Trauma and Emergency Surgery. We want to make this as interactive as possible, so please ask any questions as we go along to the Q&A button. We will try to answer them during the webinar either directly with a written reply or as part of the panel discussions. If there are a number of similar questions, we may answer them together. And if you ask a great question that we don't have time to answer during the webinar, we may send you a reply by email afterwards. There will also be a case presentation with a number of interactive polls during it. All voting will be anonymous, so please don't be reluctant to take part. We'd love to know what you think. Our main speaker will be Hayato Kurihara, Head of Emergency Surgery and Trauma at the Humanitas Research Hospital in Milan. And he will be joined by Fernando Ferreira, Coordinator of Upper GI Surgery Unit at the Pedro Hispano Hospital in Oporto, Portugal. And also by Rifat Latifi, Director of the Department of Surgery at Westchester Medical Center, New York, USA. So I think it's time for us to start with our first case presentation. So Hayato, over to you.
Thank you, Jonathan. Thank you to all the panelists. Thank you for sharing your experience. So we'll just start with a quite simple case where we have been using direct peritoneal resuscitation. So I'm Hayato Kurihara. I'm leading the Emergency Surgery and Trauma Unit at the Humanitas Clinical and Research Center here in Rozzano, Milan, Italy. So this is the story of last January, just before the outbreak of COVID-19 in Italy. This guy is a guy of 64 years old. As past medical history, he had an hepatitis C with a major depression under the drug, and he had a previous right groin hernia surgery. He has been complaining right inguinal swelling and vomit and constipation with progressive abdominal pain for the last 6 days, but he didn't come to the emergency department. So he has been waiting almost a week. And when he came to our hospital, we could find a mild abdominal pain, and there was a small bowel obstruction with a strangulated hernia at the right groin, where he had hernia surgery with a mesh few months before, actually. His blood pressure is 140 on 80, heart rate was 100, and his respiratory rate was 16. So we couldn't reduce in the abdomen. We couldn't push back the hernia back in the abdomen. And the hernia was clearly strangulated, but OR was busy at the moment. So we were supposed to wait at least 4 hours before getting access to the OR. So the first question is, what would you do? Jonathan maybe can launch the poll. Wait 4 hours or struggle for a second emergency room, which actually, for example, in my hospital is not that easy. Jonathan, you can decide when to stop the poll. Okay. So about 70% of our colleagues would struggle to find a second emergency room. Shall I go ahead?
Yeah, okay.
Okay. So I have the poll. I can't, can you take off the poll?
Okay.
Jonathan, sorry. So, and actually, probably that was the best choice because after 4 hours, the blood pressure of the patient decreased to 80 to 60, heart rate still 100, but there was a clinical deterioration, and the patient, we decided to, we finally could get access to the OR, and after endotracheal intubation, the patient developed hypertension, and and he had a need of vasopressor support. So here we have our question regarding the approach. Would you approach the patient through laparoscopy, groin, inguinal approach, or directly laparotomy? No, sorry.
Okay, so we'll end the poll there.
And the poll is there. So I see that most of the people would proceed with the midline laparotomy. Okay. And Jonathan, I have a problem because I have the poll in front of me. I can't see my slides.
Okay. Do you still have them now?
Yes. Anyway, no problem. I think I can go ahead by heart. So we decided for an inguinal approach, actually, and we had the confirmation of intraperitoneal contamination with the necrosis of the bowel with the intraperitoneal contamination. So we proceed immediately with a midline laparotomy, where we had the confirmation of a diffuse peritonitis with necrosis of the bowel loop. And of course, we had to resect the bowel. But the question now, and this is the intraoperative picture of what we found. As you can see, there is a quite interesting distinction of the bowel loops with the signs of the peritonitis. And here is the question: what would you do? Anastomosis and final closure of the abdomen, or clip it and drop and get into in a damage control surgery mood and open abdomen? And here is the question for you. Okay.
Those are the results.
Interesting. Most of our attendees got into damage control mode and with an open abdomen. And actually, this is what we did. We decided to leave the abdomen open, but we also decided to apply some intraperitoneal lavage with a direct peritoneal resuscitation. We will have a discussion regarding this issue. And then we closed the abdomen with the negative pressure wound therapy. And we started direct peritoneal resuscitation with the installation of 400 milliliter per hour with this glucose-based peritoneal lavage. And we have been waiting for 48 hours. But the problem now is regarding how would you manage the groin? Take out the mesh, or simply leave the mesh and simply use a negative pressure wound therapy? This is our third question. Interesting here. So this case, some would have been leaving the polypropylene mesh, and 57% would have just been using a negative pressure wound therapy. And this is actually what we did. We did not remove the mesh, and we just applied our negative pressure wound device. So after 48 hours, we went back to the OR, and this was the result we had with the open abdomen strategy, and with the peritoneal resuscitation, we could confirm a nice recovery of the bowel. And of course, then we decided to perform our hands-on anastomosis. We closed the abdomen, but we have been using a proline suture to improve the tension of the fascia, and then we had a direct suture of the wound. This is the technique that we have been we used, that was reported for ventral abdominal hernia. It's just a single stitch, a single suture all around the edges of the fascia, just to improve the tension of the fascia. And this, finally, we closed the skin with a continuous suture, and we applied the negative pressure, and that's the final results. Okay.
Okay, thank you, Hayato. That's a nice case. To kick the discussion off, I'm going to ask you why you decided to use direct peritoneal resuscitation in this case.
Oh, well, we have been starting to use peritoneal resuscitation in all those cases when we found a septic abdomen and bowel distension. That's the main point we will have to discuss with my lecture. So, of course, it might be controversial. What we have been experiencing in these past 2 years, when we started to use it, we see that it's much easier to clean the cavity. Of course, in combination with the negative pressure and the open abdomen. I wanted to share with you this case because you see how still was a little bit dirty, the abdomen, and the result after 48 hours. The swelling was much reduced. There were no sign of fibrin deposits on the bowel. And I think that this might be promising,
How much bowel did you resect?
It was not much. I think it was about 30 centimeters. So, and the proximal bowel was more than 1 meter.
Okay. Fernando, do you want to comment on that?
Yeah. I had a transmission block. So just to see if I understand, you did necrosectomy. I mean, you took out part of the bowel, you resected the bowel that was strangulated, and yes, from what I understand, you had 30 centimeters from trites and 70 centimeters close to the ileocecal valve. Is that correct?
No, it was much more. It was more than 1 meter, 1 meter and 20 from the trites ligament, and okay, I still had 30, 40 centimeters roundabout.
Okay. Okay then. So you basically, you took out what you were sure was necrotic,
Yes.
And in the area that you were, did you leave dubious bowel that you thought could not make it, and you hoped?
Yeah, I was not really sure because at that time the patient was in septic shock,
Okay.
and the anesthesiologist was squeezing high doses. I don't remember. I didn't report because I didn't remember. I just remember that it was on the high doses of vasopressor. So the remaining bowel, it seems all a little bit ischemic, right?
Okay, that's very interesting. Well, you know, this I find this very interesting. From what I understand, you put in a perfusion in the peritoneal resuscitation. What you're using is peritoneal dialysis fluid, correct?
Exactly.
Okay, and the basis is that you believe that it is hypertonic and it will push out the
to reduce.
Okay.
Yes.
Okay.
To
I think
improve the.
Okay. So this is very promising. I've started to use something along that line. I think hopefully after today we can get something going in the near future of hopefully a prospective study going, because, or at least a small study, because from what I see, and like you said, the patient is in shock and you have high doses of vasopressors. So the question is, what will help us get the ball back? Is it just the fact that you reduce the vasopressors, or is the peritoneal resuscitation having a big impact here? You know, because I leave my abdomen with negative pressure and no peritoneal dialysis fluid in these cases, and I go back in 48 hours, and the vast majority of the times I can reanastomose. If I can't, I'll go back in 4 or 6 or 8 days, even to the extreme, to reanastomose. But the thing is the peritoneal dialysis, do you believe, Hayato, that it can make things faster, quicker, the recuperation much faster? That's what I would like to know, number one. And number two, you also put the negative pressure down in the system, in the inguinal hernia, because you believe that it could also help clear it out, correct? But if you believe so much in your peritoneal resuscitation, you shouldn't have done that. You should have believed on your peritoneal resuscitation. Why did you go and open the way to the fat and the adipose tissue of the inguinal hernia, right, which was closed? Anyway, also when you spoke about the abdominal wall closure, something that you have published in 2006. No,
I didn't. It was not me who published.
I'm sorry, your hospital. I believe your institution, or at least in Italy, in 2006 with proline. Is this correct?
Yes.
Okay. Well, in today, you know, with the study.
No, sorry. I said proline. It was a mistake. It was PDS. I'm sorry.
Okay,
it was PDS.
Okay. Yeah, it wouldn't make sense with the contamination of that amount. Yes. Okay. So it's basically along the peritoneal resuscitation. That's my question right now.
So, as you know, Fernando, I've always been using the standard open abdomen treatment, right? And we all know that sometimes after 48 hours, you go back to the OR and the abdomen is still a little bit dirty. And but then you know, time is passing and you really want to make your anastomosis at that stage usually. And sometimes you can't because still some dirty and so on. When we started, I will be quoting in my lecture our common friend, which is Michael Segru, because the first time I've been listening to peritoneal resuscitation was from him. So I was curious and I started to try it. And what we could experience, we had the feeling that when you go to the OR for the second time, the abdomen it's much more clean than when compared to the standard open abdomen treatment. And sometimes we have still the feeling, I'm sorry I'm talking about feeling, you know, because I can't prove it, right? But we have the feeling that it's just much better. So, of course, we still need more randomized trial, good analysis. We are lacking in this. I'm advocating for prospective, maybe multi-center study, you know, but it's the same problem with the damage control surgery, you know. We don't have randomized control trials on that. So, but yes, the feeling is that we have a, maybe it's just the washout, I don't know, but I love the physiologic mindset that we have with these fluids, with the dialysis. And regarding the use of negative pressure wound therapy on the groin, yes, we had some concerns. Should we remove the mesh or not? And we knew that we had to go back to the OR after 48 hours, and that's why we decided just to leave the negative pressure also in the groin. And at that time we took the decision, well, we'll see in 48 hours. And after 48 hours, it was really clean, and we decided, okay, just close the skin and leave prophylactic negative pressure wound therapy. Maybe we were lucky, I don't know, but we had no infection.
Okay.
One of the big issues with direct peritoneal resuscitation is the indications for using it. Is that something that you're going to cover in your talk, Hayato?
Yeah, sure.
Okay. So in the meantime, Rifat, what would you, in the meantime, Rifat, what would you say to the fact that Hayato's indication now is a septic abdomen or bowel distension? Do you think that's reasonable?
I first thank you, and thank you for making me part of this. I love to be in the screen with you. I would rather be in the same room with you guys all, but we are on the screen, so let's make the best out of it. Hayato, that was beautiful case, and it brings a lot of questions in our mind. So because of you made me actually read about direct peritoneal resuscitation. For the last few days, I'm a converter. You converted me already. So I'm going to start using it. I think we have a lot of patients we can use. I think you're right, Jonathan, that septic shock, bowels, swollen bowels. Sometimes you see the swollen peritoneum, retroperitoneum. There's nothing you can do to really help these patients close the abdomen and so on. So I agree with these indications for now. I think they may be a little bit more indications that we have not used it. In the United States, really there are two centers that have produced most of the data, and you're going to go from probably, I'm sure, through that. And this is the University of Kentucky, and now University of Arizona is starting it, and we're going to start in our center actually doing that because we have plenty of patients where we can use it. One point that I learned during this preparation, I think it is the vasodilation effect of the peritoneal dialysis that is doing it, and not just because you're washing it out. Because yes, animal data did not help when they use physiologic water, just normal saline. So I think there is something more to that, what we put in a patient with this physiologic, with the peritoneal dialysis.
Shall we move on to your talk, Hayato? And then we can carry on the great discussion afterwards.
Right. Okay. Just a minute. I'm sharing my screen again. Okay. Right. So just a very few hints regarding the open abdomen. Why are we leaving the abdomen open? Because I'm sure we have some, among the attendees, we have some residents too. So mainly 3 causes: inability to eliminate or control the source of the infection due to patient critical condition, excessive peritoneal swelling. That means that probably the patient might develop an abdominal compartment syndrome, or we had an incomplete debridement. Those are the 3 main conditions we need. I'm talking about a septic patient. Those are the situation where we should leave the abdomen open. And this is something that can happen sometimes. We might have some challenging open abdomen. That's one of my first open abdomen cases where I totally lost the control of the abdomen. So we might have a very important fluid loss with an imbalance of the fluids, protein loss, and we might have enterotransferred fistula, which is the nightmare of the acute care surgeon. And of course, loss of domain due to the edema and the severe fascial retraction. So the main goal is the definitive fascial closure. And we know that with the open abdomen strategy and negative pressure wound therapy, we have to manage the abdominal wall. We can reach the fascial closure with tension suture with the mesh. We might have a component anterior separation technique. We might have different techniques. I think we will need 3-4 days to discuss about that. And why peritoneal resuscitation? These are the 2 guys that Mike Rotondo and Bill Schwab that described for the very first time the damage control surgery that was aimed in trauma surgery to normalize the central hemodynamic parameters. But damage control surgery may not restore the blood flow to visceral organs. And we still might have a progressive vasoconstriction following the shock of ischemia that is caused by the endothelial cell dysfunction. And the persistent hyperperfusion at the bowel level can lead to derangements in fluid exchange, electrolyte handling, tissue ischemia, and worsening of the inflammation. So we have to think at the tissue level. These are abnormalities in the microcirculatory perfusion and cellular function are hypothesized to contribute to prolonged tissue hypoxia with cellular injury, multi-organ failure, and of course death. So what do we have after a bleeding patient in shock? We have a vasoconstriction with blood shunt to noble organs. We have a prolonged hyperperfusion, and that causes cytokines, inflammatory cytokines spreading with intestinal mucosa sloughing and microvascular at the level of the endothelium with an increased intestinal permeability with the bacterial translocation, sepsis, and we might have visceral organs damage and edema. So despite the normalization of the central vital parameters after post-conventional resuscitation, we still have a hyperperfusion at the level of the bowel in most of the patients that underwent damage control surgery. So the idea behind that is that peritoneal resuscitation in terms of the use of lavage with commercial peritoneal dialysis solution, they might cause a vasodilatation effect on visceral and parietal arterioles with a generalized dilation effect at the level of the intestinal micro circulation. So the idea is to use this hyperosmolar dextrose-based solution in combination with conventional resuscitation, of course. This might prevent the progressive intestinal vasoconstriction and hyperperfusion. So reducing the edema. So the first idea came from the center of Louisville in Kentucky, and that was at the beginning was experimental, and they could show that the pH in the bathing solution in the patient with the hemorrhagic shock, the pH was lower during the resuscitation and post-resuscitation period in the group that were treated with peritoneal resuscitation. And also the blood flow at a microvascular level was better when peritoneal resuscitation was used. So the first reports that were published in 2004 and 2005 with the use of peritoneal resuscitation, that it's in patient with hemorrhagic shock, there was immunomodulation and anti-fluid sequestration that resulted in an improved outcome. The main concerns at the beginning was that there could have been an adverse effect on the hemodynamics of the patient, but this didn't happen, actually. So in 2010, on the Journal of American College of Surgeons was published a first series of cases of patients that underwent direct peritoneal resuscitation and were compared with conventional resuscitation. And in such a study from the same group of Kentucky, the time to definitive abdominal closure was significantly less in the DPR group when compared to standard resuscitation. And also the rate of primary fascial closure was higher. And also the definitive wound closure was better when compared with other closure techniques like with the Whitman patch. So it seems that direct peritoneal resuscitation could mitigate the intra-abdominal complication when associated, of course, with an open abdomen and a damage control surgery strategy. In terms of time to closure, in terms of primary fascial closure, and also in terms of intra-abdominal complication and develop of ventral hernia after 6 months. So since the results were promising with the hemorrhagic patient, the same group decided to apply direct peritoneal resuscitation also in septic abdomen. In case of a patient with pancreatitis, perforation, bowel obstruction, and ischemic enterocolitis. And again, in the DPR group, there was a higher rate of definitive fascial closure, a shorter time to definitive fascial closure, improve of the physiology of the patient too. And I think that this is one of the most interesting points because there was a decrease Apache 2 and SOFA score at 48 hours. And there were less also, fewer abdominal complications, less days on the ventilator, and there was a lower overall mortality at 30 days. So why did we start to use it? Probably after the talk with our common friends, Michael, I was really impressed by the initial reports from Michael, and we started to study a little bit about that, and we just started to use. The system is really quite simple. We just need your open abdomen strategy with a negative pressure wound therapy and the use of a Jackson Pratt or round Blake drain. We use sometimes we use the Blake drain and sometimes we use the Jackson Pratt. And we leave the drain at the roots of the mesentery. Then we close our abdomen. Then we start with a bolus of 100 cc of hypertonic 2.5, which is the one in the middle between the 3 different solutions for peritoneal dialysis. and then we start to instill and make a lavage at a rate of 400 cc per hour. So it's quite easy to set up. The results it seems to be quite promising, but of course everything should be validated. And here it is. Okay.
Okay, thank you, Hayato, for that great summary and presentation. I noticed in your drawing diagram at the end that the way that you do it is to have one essential tube with dialysis fluid going in and then 2 tubes with it coming out. I know other people recommend using 2 tubes to put in the dialysis fluid on both sides, into both, essentially both paracolic gutters, and just 1 drainage tube coming out. Is there a reason why you've gone for the one drain in and 2 drains out approach?
No, I think we don't like to leave many drains. We already have our negative pressure wound therapy. The only concern is that sometimes you're wasting too many collectors. So that's why we sometimes we use just the standard vacuum system. But if you leave it to the root, sometimes we have an alternate negative pressure wound therapy, so that the bowel can, let's say, be soaked, the viscera can be soaked in the solution, and then we take it out. We have seen that when you leave the drain at the root of the mesentery, well, usually it's enough.
I know that you'll lose some things like amino acids and vitamins and so on with a peritoneal dialysis fluid. Have you noticed any problems in electrolyte management in patients who have this form of management?
That was the main concerns with our intensivist, and actually, to tell you the truth, we had concerns too, but actually we did not see any electrolyte balance differences. It has never been a problem. I was, tell you the truth, I was surprised about that, but it seems it didn't affect.
Okay, it's very, very promising, very interesting mechanism and study and so on. And as we identified before, part of the defining of this will be to identify those patients who need this form of management. Rifat, do you have any comments that you want to make on the presentation?
Yeah, that was great. Great presentation and right to the point, and I really love it. So far, and you know, again, I have to admit, what I read recently on it and in the past had to do with damage control surgery patients. I'm wondering if one can use, and I saw one of the slides you mentioned pancreatitis. I have 2 patients right now in a ICU who are severe pancreatitis. One is gallstone pancreatitis, one is alcohol pancreatitis induced. Don't need an operation yet, did not have an operation, and we're hoping not to have unless but they're both really sick. They are on bilevel ventilatory support with PO2 FiO2 ratio just barely over 201, and there's been like 70 and less than 100 in the other one. I'm wondering if one can use this therapy in guys like that. We do not need to open their abdomen. So we would have to do some sort of a, maybe laparoscopically assisted or some sort of to put the drains. And I'm wondering if any of you guys have any experience with that kind of thing.
No, actually, I didn't. Lucky, we in my hospital we do not see many acute pancreatitis, but I'm waiting for the next case, and I don't have an answer for that. I don't have an answer to that, but you know, in theory, it should work. It should work.
Jonathan, what do you think?
I think it's a very interesting prospect, and I was thinking along the same lines when I was doing my background reading for this as well, that if you could do that, then you might be able to save a lot of trouble for patients. I think it's a good idea.
Well, I know exactly where I'm going to go right from here. I'm going to talk to my nephrologist, who happened to be chief medical officer of the hospital. And I'm going to drop all these references in front of her desk and say, listen, we need to do this. So we're totally going to do it.
I'm more moderate in that sense. We have quite a few pancreatitis at our hospital, severe pancreatitis, about 5 or 6, not quite a few, but 5 or 6 very severe pancreatitis a year. And at the moment, we have one open abdomen with severe pancreatitis who about 2 weeks ago had abdominal compartment syndrome and a very septic shock associated with infected necrosis. So we have an open abdomen, we have negative pressure. We have been doing some installation of normal fluid, but we use it with the intent to clean out the necrosis. We don't use the peritoneal fluid because in my hospital, peritoneal dialysis is not done. But for me, what makes sense is this is an option perhaps for the future. I'm thinking about it for this patient. And I think we should, as surgeons, always keep with our approach, a step-up approach. So, non-invasive as always, and also consider that if we are going to do peritoneal lavage in a patient, such as you have mentioned, Rifat, that we also have the risk to introduce a gateway of infection. So we have to be careful also with that, just being devil's advocate here. With regards to this, I'm just wondering, from my calculations, you use about 10 liters a day, Hayato, of fluid. How much does this cost per liter? I'm just wondering, I want to convince my ICU people, how much does this cost?
No, yeah, it's very easy. If you steal the bags to the nephrologist, it's free.
Okay.
So actually, no, I'm sorry for my stupid reply. Actually, I don't know.
See, that's it. It's 10 liters a day. And in my hospital, we do not do peritoneal dialysis. We do hemofiltration, hemodialysis. And that's what I was wondering, what is there an option? Is there anything written with other types of fluids? So I'm basically ignorant in that point. And just thinking already in out of the box of trying to replicate the fluid myself. So that's it.
If I can just make just a small comment. This dose that was reported by Smith from Kentucky Group in 2014, they say 800 cc's first hour followed by 400 cc's an hour.
Yeah.
Maybe this calls for another study. You could do 200 versus 400. How about if we just infuse it, leave it there for a few hours, and then take it out? So I think that a lot of things that I'm not smart enough to know all the answers to these questions, but I think it's a really good opportunity to do a lot of work in this field.
Jonathan, may I tell something?
It's Mauro.
Yeah, Mauro, go.
Oh, sorry. First of all, sorry for being late, but I was really in awe, and greetings to all. I have a very, very short experience on direct peritoneal resuscitation, and I would like to highlight something that Fernando told about. So I had experience in my former hospital, which was an hospital without a service of peritoneal dialysis. So the first time I was helped by a nurse that thought to ask the referral hospital 10 kilometers far, and in Friday evening during the night quiet was 8 p.m. we got fluids enough, and the heater for having a warm fluid, because it's very important to have warm fluid at the same temperature. So it could be possible even in hospital without. And a very practical thing was that thereafter we tried to store some bags of peritoneal dialysis fluid in order to be prepared, because the drain is always there. Negative pressure is not a problem, because you can establish a Barker pack, and you can do anyway. But if you don't have the right peritoneal dialysis fluid in your hospital, it's a problem. It doesn't cost so much, because I know that it costs something like 25 euros per 5 liters. So it's really cheap. Okay. In my current hospital, we have a peritoneal dialysis service joined with this unit, so we can do without problems. But anyway, in any case, you have to establish a protocol, and you have to have a checklist, all things prepared, because this could happen. You could think about at any time during the day or during the week. So if you don't have with you, so I was very lucky the first time, but was really it happened, but could not be the standard. A second thing, I don't know if Hayato told about yet, but because I was late, is that you don't have to use commercial device canisters. Yeah. Otherwise, your Hayato, did you already told about?
Yeah, I said what we did. Yes.
Okay. And it's really easy to have this system accepted by intensivists, because if the seating of your open abdomen is correct, it's easy, and the only thing is to get all the connectors in order to have a system well working. But otherwise, it's very simple. I don't have experience in acute pancreatitis, but the last case I did in my new hospital here was quite similar, because I prepared the case, but anyway, it's not finalized, but was a case of a gastric blowout in a very young guy, and in the day after the first operation, the content of the stomach was something like 5 to 6 liters of gastric content with lipase, because the serum level of lipase was more than 5,000 in this patient, and the first diagnosis was acute pancreatitis, but was not so. And the day following the first operation in the abdomen, there was a kind of ongoing necrosis due to the characteristics of the fluid. So, and it worked. To be honest, it works. As Hayato told about, is a feeling, because we cannot measure, or it's difficult to measure. That's all.
I have a question, Jonathan. Is it possible? Yeah.
Of course, yeah, please.
So, well, it's a remark also. So from what I've just seen, thanks, Mauro, it's about 50 euros for a day for the direct peritoneal resuscitation, or 70 US, I guess. And so we've seen this as cheap, relatively cheap. Rifat just mentioned that you know, he'll be talking to his ICU people. And the question is this, you know, how many liters do we need? Because we know, we've learned in the past that peritoneal resuscitation, if I'm not mistaken, you would only need 5 liters per session. But here you're doing 10 liters. So that's the question, you know, if your peritoneum is so sick Do you have to put double the amount? Is this something that's by eye? Or, I think this is something that we have to start speaking with our colleagues and see what studies do we have with very sick peritoneum to see how much, what is the minimum that we need to make the peritoneal, the direct peritoneal resuscitation. I think that's the aspect that should come out of this meeting. First of all, that how much do we really need? Number one. Number two, I think that this is a promising event. We're seeing many aspects, but of course we have to start to of course keep in view what we have to do as surgeons, because it's almost like negative pressure. In the beginning, I remember in the beginning people would put negative pressure on horrible septic abdomens and hope it would get better quickly, and we know that as surgeons you have to have a septic control, and it's the same as in the pancreatitis. If you have sepsis and severe sepsis and pancreatitis, if you don't clear out that necrosis, I don't believe personally, correct me if I'm wrong, but the peritoneal dialysis will not penetrate that horrible necrotic stiff tissue. Do you think not, Rifat? Do you think that it's worth trying? For example, in your patient that has the peritoneum full of inflammatory mediators, and that's what you're going to try to do, to clean out the inflammatory mediators alone? Yeah. Or do you think that you can also hope to go and clear out the pancreatic necrosis?
Well, Fernando, you're making really a great point. I don't know the answer. That the fact of the matter is, but if we maybe if we do this, maybe we go laparoscopically and we just open the lesser sac a little bit, so it can perhaps kind of bathe the lesser sac a little bit more. But we all know that you don't have to find just pus in the pancreatitis. We usually get 3 or 4 a year that are really bad. For the most part, they're not, but 3 or 4, maybe 5, that would be really a lot. I think last year we had 6 or 7, but it's aberration. It's not normal. So, and you go there and you look for that pus and you don't find it because they are so bad, or they have abdominal compartment syndrome or something like that. When you see pus, you're in heaven. At least you wash it out, they clean it and so on. And I had left a lot of drains in the pancreas. I use a triple hose where it's same drain. I infuse fluid and the other tube is pulling it out, and so I don't really know what would we do, but there's something to study both in the lab and frankly, these patients, there's nothing to lose if we use that. As long as, but one question comes to me, and maybe Hayato, you can answer, or whoever knows the answer. What do you do with the IV fluids that you give into the patients? Do you reduce it? Do you keep the same amount? Let's just say they take 100 cc's an hour. What do you do with that? And then when do you start feeding these patients? Do we know exactly? So let's just say that 3-4 days and you went back 48 hours later on your case. But if you had done, let's assume that you did the anastomosis and it was just kind of still ugly, but you closed it. How long should we keep with this peritoneal dialysis, resuscitation? So there are really a lot of questions, a fascinating question. I'm so glad you invited me to this, because I actually just became richer in my mind and more excited to do some good things.
Well, actually, thank you, Rifat, for your comment. And first, we have been discussing with intensivists because I'm not lucky, maybe like Mauro, but at the beginning in my hospital, our intensivists were reluctant. I think that they were scared about the fact that we use the word resuscitation, What we have seen that the fluid management did not change for them. Regarding feeding, well, we just follow the same rules. So in case of septic patient, we wait until we have the possibility to have a low level of vasopressor before starting the feeding the patients, right? Because we are always a little bit scared about feeding the patient too early if they are under high doses of vasopressor. And of course, if we have, we do not have bowel discontinuity. But actually, the standard treatment of the intensivists, it didn't seem to change. But the patient, again, it's still gut feeling. It's simply improving. But we just used these peritoneal resuscitation in about 10 cases, so it's nothing, right?
It's something.
Thank you.
I would like to add something to the speech of Hayato. I think that Rifat asked how many days you use it, or how long is the use of peritoneal resuscitation. I have less cases than Hayato, and the first two cases we used for 3 and respectively 2 days. In the last case, we used 2 times, because you used for 5 days, I remember 4 or 5 days the first time. Then we were satisfied. We left the abdomen open, trying to close. 2 days after, due to the pathophysiology I told you before, necrosis and bowel loops were again swollen, and we again established for 2 days DPR with good, let me say, results. So you can even stop, and you can. I have 1 case for which we stopped and redo again DPR. Finally, in 2 out 4 cases, something like that, intensivists were used CVVH, so filtration during direct peritoneal resuscitation. So and they needed to balance, because for sure is a peritoneal dialysis fluid, so it works even for filtration and for renal function, and they had to really monitoring very well the way to use their system for renal filtration.
Okay.
So we have a system which looks very, very promising. We still haven't decided yet or refined the indications for using it. So we don't quite know when to use it. We don't really know how much to use, and we don't really know how long to use it for. But like all good research, these are all things that can be taken forwards in the future. Can I ask Hayato for a sort of comment, a final comment, if you like, on the direct peritoneal lavage and resuscitation?
Yeah, I would like to make a comment, not directly on direct peritoneal lavage, but just a comment on my feeling on how it's useful to have the possibility to share our small experience with people like Fernando and Rifat. So I'm just very grateful to you, and I think that from the next case, I will think much more about regarding your suggestions. There are many concerns about the use of this. This is, it's like the new kid on the block. And I think we should gather together to make some research on that. And yes, that's it. Grateful to the European Trauma and Emergency Surgery Society, and grateful to all of you for your comments.
Okay, Fernando, do you have a
Thank
final comment that you'd like to make?
Well, on my side, I'd like to thank Alan, Diego, and Rifat, and Mauro. And in the sense,
Have a bad connection.
Yeah, we've lost your connection there. Rifat, your final words on the subject, perhaps, or at least your final words for the moment.
Thank you so much. You know, I'm excited about this. And I'm sitting here. The first publication was in early 2000, and it was as convincing then as it's convincing now. Why it took us so long, as a surgical community, to adopt it a little bit faster. So maybe this is a new era, because although this may seem like a new kid in the block, this kid had been around the block, but he didn't get in the house. So he just stayed outside on the street for the last almost 2 decades. So I think this really is going to be a fascinating thing to do. So I'm really, again, grateful for you guys inviting me, and I'm totally energized on a prospect to do this thing. And I think we should do it. And maybe we should start an international study where we all do a registry and we report on these guys. And maybe we relax a little bit our indications. If you go there and you do a patient who had perforated diverticulitis, we all know that we cannot wash it out, everything. And you see the bowels, maybe they look a little bit hyperemic, a little bit, particularly if they wear in their pus. Why not use those for, maybe close it completely, close the abdomen, close the fascia, but just use it for a couple of days, 2 days, 3 days. So I think this indication is going to be interesting we all agree on those things. Mm-hmm. But great job, Hayato. Great job, Jonathan. Mauro, good to see you, and everyone else. Fernando, sorry we lost you for a second.
Yeah. No, thank you. Thank you.
Oh, you're back. Okay.
I'm back, and I just heard everything you said, which is great. Just really quick, before I get lost again, 3 to 5 days treatment. And we all have the feeling, and this is the word we're using, feeling, that this works. But in a sense, this translates to anecdotal reports, you know. So again, what we need is to, one of these days, get together, at least in a webinar, and share our reports all together. And based on those reports, start to implement the indications. I think that this is the new kid on the block, because it has to involve not only us, but nephrologists and urologists, or at least nephrologists. And I've never seen many associations between surgeons and nephrologists. So this is going to be challenging. And I, for myself, what I'll do right now is that tomorrow, when I'm going to revisit the abdomen of this patient, so I'm going to take a few pictures, and I'll send them to you, and I'm going to try to convince my ICU personnel to start using the peritoneal dialysis.
That's great. That's a great start.
Okay.
That's great contribution of this conference.
Indeed, indeed.
Yeah.
Okay, Mauro, do you have anything you want to say before we close?
No, I think that I agree. So that sharing ideas, and for example, the idea of having a registry could be maybe bring by ESTES and even National Society, and do something really quickly and simple in order to share indication and maybe even modification like Rifat suggested in order to, for example, fluids. And yes, because at the moment, the first time is a feeling, but it's a good feeling. So why not to go ahead?
Okay, that's great. We've identified a very good way forward, setting up a registry, looking at the work we do, communicating more with each other, working with our nephrologists. I think it's been a very interesting, a very good webinar that we've had this evening, and I hope it's stimulated a lot of thought, both among the panel and people who've been watching it as well. What I'd like to do is take the opportunity now to thank our fabulous backstage crew, without whom this would not have been possible. Taking the opportunity to thank my good friends Alan Biloslavo and Diego Mariani, my co-host Mauro Zago, and our panelists Hayato Kurihara, Fernando Ferreira, and Rifat Latifi. Thank you for joining us. I hope you've enjoyed this webinar, and will join us again in 2 weeks for an ESTES webinar on fragility fractures of the pelvis, and again in 2 weeks' time for a webinar on RIBOA and endovascular resuscitation in trauma. I hope you've enjoyed it, and I hope that we can see you again soon.
Okay.
Thank you.
Thank you.
Thank you to all.
Bye-bye to everyone.
Bye to everyone.
Okay,
Thank
bye-bye.
you.
Bye.